Hello, Scott. How are you doing?
Fine, thanks.
I think we should probably get started. It's 11:03. I see we still have people joining us.
Mm-hmm.
Are
That
you
sounds
ready?
fine. Anytime.
Okay.
You ready for me to go?
Yes. Please start. Everyone else can just hear you, and then they can add their questions,
Okay.
and we can you can review those when you're finished your presentation.
All right. Very good.
Thanks.
Thanks, Cindy. Thanks to My Outcomes. It's a pleasure to be with you all, chat about feedback-informed treatment and how to make your agency more effective and more efficient. I am Scott Miller, and you can get the pictures that I'll be showing today during this webinar on my website, which is at scottdmiller.com, Scott D as in David, Miller.com. And scroll down to the fourth bullet point where it says Scholarly Publications, Handout, and Vita, and just look for the feedback-informed treatment presentation, and there you'll find a full-color PDF. If you are using Twitter, I would love to connect with you as well, share what's happening in the world of feedback-informed treatment on a daily basis. My Twitter handle is Scott_DM. And finally, let me just mention something we'll come back to as it regards the implementation of feedback-informed work in your particular agency or setting, and that's the Center for Clinical Excellence. This is the largest organization of providers, agencies, and researchers around the world that are working to improve both the quality and the outcome of behavioral health services. There are thousands and thousands of members in countries, as I said, around the globe, and they meet to support and learn and share from each other. This is entirely free, and I hope you'll join us there. The process is fairly simple. Over to the right where it says how to join the ICCE, you simply click on step 1. You'll get an invitation code, be able to come back, create an avatar, and participate in the hundreds of forums on various topics, access video, as well as this document library of people who contribute to the ICCE. The notion is that expertise always has to be executed locally. And so folks in their local areas are talking about how they apply the ideas you're about to hear about in their local settings. Again, that's at centerforclinicalexcellence.com. And you know, every week I leave the fair city of Chicago, which sometimes looks more like this than at other times, and I get on a plane and I fly somewhere, and I'm talking to therapists, administrators, I'm talking to researchers, payers, business executives, and of course regulators, the people who pass the rules about our profession. And as I'm talking and meeting therapists and agency directors and such, I hear one thing and one thing only, and that is, what does the data say about behavioral health? And the data is actually quite good. At the same time, therapists are also telling me that they are truly struggling with increasing caseloads, the amount of regulation and red tape that they have to contend with, and documentation. We sent out an email last week, and there was a typo in this email. We should have said that the average clinician spends 30% of their available time on the job completing the paperwork required by the various funding bodies and regulators. And somebody didn't proof the email very well. That would be me. And it said 3%. And I have to tell you, I got 2 or 3 hostile emails from clinicians in the United States saying, what are you talking about, 3%? We spend at least 30% of our time. That's the figure. I tell the funders that if they want to improve productivity, one thing that they could do straight away would be to cut the paperwork that clinicians have to deal with. They're also talking about funding challenges. Right here in my home city of Chicago, just 4 weeks ago, on the news you may have seen there were protests about NATO being in town. But there were also other protests, actually larger, about several mental health, publicly funded mental health clinics that have been closed without warning due to lack of funds. And last but not least, in this era of not having much money, there's also a huge demand for accountability. How are we going to prove that what we do is of value and merit? So it's tough. And the question is, what kinds of solutions are on offer for agencies struggling with these particular issues and concerns. And when I talk to clinicians and present, they often tell me that one of the main things they're told is that they have to do more with less. I love this little cartoon from Savage Chickens where the manager says, do more with less, and the staff, portrayed as a chicken, say, that doesn't really work. And the manager says, and neither will you if you don't do more with less. While this may seem funny, it's also a reality, at least for the clinicians that were working in the publicly funded clinics here in Chicago. And if they're not told to do more with less, the other thing they're often told to do is that they can work smarter, not harder. This is the rise of so-called evidence-based practices and treatments. If you were just trained in a specific model of therapy, you would be able to deliver more effective services. So the presenter shows on his screen, work smarter, not harder, and then he adds the caveat, which is sadly true. Then again, if you're not so very smart, it's okay just to work harder. And I don't meet any therapists who are saying to me of late that they don't have enough to do. Waiting lists, short amount of funding, and clients whose needs are not getting any less as we go forward. And again, the question is really, what are clinicians able to do in order to improve their lot? What can agencies do in order to survive and thrive in this era that we're currently living in? And so there are some things, and it starts with looking at what the research evidence actually says. And here, the evidence is quite good. So let's just talk about briefly what the data say about the work that we all do. Number one, in most studies of treatment conducted over the last 40 years, the average treated person is better off than 80% of people with similar problems but that don't get help. Now, I want you to note what I did not say. I did not say that we had an 80% success rate or that the clinicians you manage have an 80% success rate. This is the strange, rarefied way that researchers speak to one another. It's called an effect size. How big of an effect do you get compared to the untreated group? What do we know? Regardless of treatment, regardless of problem, the average treated client in those studies is better off than 80% of the untreated sample. That effect size is actually quite large. In fact, it exceeds and equals in most cases medical treatments. For example, the effect size of psychological treatments is on par with coronary artery bypass surgery. And as I sometimes say in my workshops, we do our work without leaving scars most of the time. Few people, if any, die from psychological treatments. Every week, people die in hospitals and as a result of medical care. What we do really does work. It works quite well. Hanging on to this is important as we move forward with this topic of how can we improve the outcomes of what we do. And if you look at average mental health counselors and professionals, they achieve outcomes on par with success rates obtained in tightly controlled randomized clinical trials. Why is that important to know? Well, you're being told to have your staff adopt evidence-based practices, models that are manualized and can be deliverable in a short period of time. But the truth is that this whole approach begs the question, because when you measure the outcomes of clinicians working in their real-world work settings, they're already achieving outcomes on average on par with those obtained in those tightly controlled trials. Plus, they're doing so with a much more difficult and challenging clinical population. Although our field has made some progress in this area, most randomized clinical trials continue to suffer from single diagnosis treatment approaches, meaning that the clients in the sample are limited to a single presenting problem or diagnosis. When was the last time your clinicians were working with clients who had a single problem? If they were, I promise you, they would be considerate a vacation. So what we do does work. It works really quite well. That's the good news. Let it sink in. Nothing to be worried about our outcomes in general. Let's move on to some more troubling news. And that is that our outcomes, since they first started gathering this kind of outcome data, 1976, 27 years ago, the first meta-analysis was published by Smith and Glass. Over that 27-year period, our outcomes have stayed the same. Remember, they started good, but they haven't gotten any better. Contrast that with, say, the Olympics coming up here in the UK in just a week or so. In the Olympics, the performance in every single Olympic event has improved in most cases, or in some cases rather, by 50% over the last 100 years. In psychotherapy, no difference. The question would be, how could that be the case? We have an explosion in models, in number of diagnoses, in treatment approach, certainly in the number of clinicians providing services, and yet our outcomes have remained flat. So it's a huge challenge to convince people to pay for what we do when we're driving the same kind of vehicle that we were driving in 1976. Think about the car you drove in 1976. Think about this. No cell phones, no desktop computers. We were wearing bell bottoms and super wide ties. We're still wearing those ties nowadays. We look dated to the funders. There are some other issues. 3 stubborn facts that we think, if addressed, would lead agencies to the forefront in providing quality and effective and efficient behavioral health services. Here are those facts. Our dropout rates, these are robust figures. They go back a long way. They are true in Australia, in Canada, and in the US, and in the UK. Our dropout rates, that is, people unilaterally deciding to terminate services prior to achieving a reliable change in their behavior, average 47%. Another way of looking at this is we do great work with the people who stay. Unfortunately, half of our customers decide that they'd rather be mentally ill than have to meet with us one more time. It's a drag, and it's an area of inefficiency that we could do something about. Number 2, and perhaps more frightening, mental health professionals, the research literature says, fail to identify cases A, at risk for dropping out, or B, at risk for deterioration. It's not that clinicians don't think that they're capable. They do. But the data indicate they're not. Last time this research was done was by Scott Hannon. Scott Hannon gave 25 therapists 400 different clients and asked them to identify the ones that were deteriorating while they were treated. Scott Hannon also told the therapist ahead of time that the average deterioration rate was 10%. And yet in this study, at the conclusion, therapists identified only 1 failing case correctly. 1. Number 3 is that 1 out of 10 consumers accounts for 60 to 70% of the expenditures in behavioral health. Think about that for a second. These clients collect like plaque on the arteries of the treatment system. By the way, it's the same in medicine. A very small number, 20 to 30%, account for upwards of 70 to 80% of medical costs. In our field, it's no different. A small number fill up on clients or clinicians' caseloads. They don't go away. Clinicians don't seem to see it. They clog the arteries of the system. What have we adopted as a solution? We've tried to change the service delivery for all clients rather than targeting those clients who do not get better for something different. In order to be able to do that, we have to know what to look for in our caseloads to identify those at risk for dropping out or not getting better. Another issue is a manager of an agency or public health clinic is to know that the effectiveness of the average helper plateaus quite early in their career. I won't bore you with the details. The person who's looked at this is the expert on expert, Kay Anders Eriksson, who's been working with our team at the Center for Clinical Excellence, identifying and understanding why some therapists just don't get better at what they do. And in fact, the data indicate going back 10, 15, 20 years, there's little or no difference in outcome between professionals, students, and paraprofessionals. This explains, in part, why there's a trend towards using peer counselors. Now, I'm not against this. The truth is the same will eventually apply to peer counselors. They won't get better after a short period of rapid growth. The question is, what can we do about these various factors that contribute to outcomes, especially when therapists are struggling to balance so many difficulties and challenges. Paperwork, rising caseloads, funding challenges, regulatory demands, changing clinical problems, quality assurance standards, accountability, etc. What can clinicians do? What can agency directors do? What should we keep our eye on? Well, Our team has an idea about this, and we've been implementing these ideas around the world for the last decade, looking at helping clinicians keep their eye on the elements in clinical practice that are most predictive of clients staying engaged in the service and getting the outcomes that they have presented for service for. And there are two. Number one is the alliance, the relationship between the counselor and the client. Now, I know in this era of evidence-based practice, talking about relying on the alliance may sound simplistic. But here again, recall, clinicians' outcomes on average don't improve over the course of their career. Clinicians experience themselves as getting better. When you look at their actual data, after a short period of rapid growth in the beginning, most plateau and they don't get better despite what they believe. So one of the areas that we've noticed clinicians assume they have a particular skill, but often comes up short, is in their alliance formation skills. After all, it has to be one of the factors accounting for dropout. Research on the power of that relationship is reflected in over 1,100 separate research findings. It is, in fact, the single most evidence-based concept in the treatment literature. And yet, when was the last time you attended a staff meeting where the quality of the relationship between the counselor and the client was the subject of discussion, rather than, say, the treatment being used or the nature of the diagnosis? I suggest it's probably rare. The nice thing about the research on the alliance is that researchers also agree on the basic components of the alliance. We like to use a three-legged stool as an analogy when talking and teaching about that relationship. Why? Because the alliance is designed to keep clients engaged, and engagement in treatment is the #1 threat to outcomes. What can therapists do to improve their alliances? Well, mutually and collaboratively determine goals. Mutually and collaboratively determined means or methods, checking in to make sure that the therapist's experience of that relationship is the same as the client's, and last but not least, meeting the client's preferences. Now here is the wrinkle in the alliance research, and I'll introduce it by talking about a study that was done by another hero of mine, Baldwin. Baldwin did a study of 331 people presenting for services, seen by 81 clinicians. Here's what Baldwin noticed. There was differences in outcome between the clinicians. In other words, some got better outcomes, some had poorer outcomes. One more time, let that sink in. It is so different than what we were trained, what I was trained to think about when I approached outcome. I was trained to think that the outcome depends on the difficulty of the problem being presented and the treatment, the quality of the treatment presented. Here's what Baldwin is saying. He's saying that the difference in outcome depends on who treats the client. And the difference between those treaters boils down to their variability in being able to provide a good alliance to their clients. Consumer variability in the alliance, by contrast, is unrelated to outcome. Here again, I think it's curious because essentially what our field has done is spend a great deal of time categorizing the clients according to their problems and delivering treatments to them, as opposed to trying to figure out what's it going to take for me, therapist, to connect better with that client. Now remember, I know this message gets tough. What I said in the beginning is our outcomes are good compared to medicine. What this presentation is about is how can we as an agency, how can we as individual clinicians push our effectiveness to the next level? Well, it looks like we need to look at ourselves. It looks like agency managers need to put in place a structure that will help therapists look at how they connect with their clients in terms of the alliance. That's the first piece. The clinical implications, in other words, proposed by Baldwin, are that therapists need to monitor their contribution of the alliance. If you're an agency manager, that means in place. We have to put structures that enable the therapist to monitor what they contribute to the alliance. There have to be structures in place that provide feedback to therapists about their alliances, and then training to help therapists develop stronger relationships with their clients. Most therapists do a good job, except when they don't. What should they do to improve? Not learn another evidence-based treatment approach. Rather, focus on those times when they don't engage that particular client. That's #1. The second thing to keep your eye on, in addition to the alliance, is outcomes. back in the early 80s, actually late 70s and early 80s, Ken Howard worked in obscurity at Northwestern here in Chicago, and talking about how clients experience change in treatment. He published a study that was largely ignored at the time, but has now seen as prescient looking back on it some 40, 30 years later. And that is his study, which showed that most of change begins in the beginning of treatment. In other words, 35 to 65% of people, he found, improved within the first 7 visits. Now, if you think back to the late 1970s and early 80s, Ken Howard was working with therapists who were largely of a long-term treatment mindset, and yet their clients couldn't disagree more. Most of the benefit that they got occurred earlier rather than later. Now, wait with me here, because I am not making a proposal for brief therapy. In fact, if you look at Ken Howard's graph, which is on the left, you'll see that the majority of change did happen early on. But if clients changed early on, they were likely to continue changing, albeit at slower rates over time. Baldwin, in his study, replicated and extended Howard's findings. His graph is on the right. And you can see that across levels of dysfunction or distress, all clients needed to be on their way earlier rather than later. What can we conclude from this? If a particular therapist working with a given client in a given setting is going to be helpful, that client should show measurable improvement earlier rather than later. Let me say it again. If a particular therapist using a given model in a specific setting is working with that client should begin to show signs of improvement sooner rather than later. How soon? Look at the graph. First 6 to 8 weeks of care. Even for clients who are the most distressed, 50% of the change happens within 3 months. If that change is not forthcoming, then the therapist needs to do something different. In this way, we catch that 1 out of 10 clients that accounts for 60 to 70% of the expenditures. In other words, in addition to monitoring our alliance with clients, we need to monitor the outcomes. It just so happens that our team has made available to clinicians and agencies 2 very simple measures. One is the outcome rating scale. The other is the session rating scale. The one on the right, the SRS, gives feedback to the clinician about the alliance. The one on the left gives feedback to the clinician about the outcome. This is done session after session with the therapist and client talking about both the status of the relationship and the outcome of the service. By the way, you can go to my website, scottdmiller.com, agree to the terms and conditions, and download these measures for individual practitioner use for free. They're also available in 20+ different languages, everything from Arabic to Yiddish. So please avail yourselves of those. Tell your clinicians to go get them as well so that they can begin using them. So here's what the data say that I think will be of interest to most agency directors. Currently, there are 13 randomized clinical trials involving over 12,000 clinically, culturally, and economically diverse consumers. And in those studies, they've shown that when therapists routinely monitor the outcome of the service, you as much as double the effect size. That is reliable and clinical significant change. Let me just say that again. You improve the effectiveness of treatment 2-fold. One of the studies that is available, that was done by Morten Anker in Norway, shows that you tripled the effectiveness. And here's what's curious. The same therapist, when they use the measures, gets 3 times the results as when they are not using the measures. Decreases dropout rates as much as half. Now, if you're an agency director, you know how much lost productivity there is when clinicians have clients that no-show. Let me just make one side comment about that, because our current way of measuring productivity, at least in the United States and in other places I've been to, often complicates this enormously. When we incentivize, when we incent clinicians to have butts in seats, when we measure their productivity by the number of clients seen per week, we actually create a perverse incentive. That is, clinicians are likely to schedule clients, not consciously, but they are likely to schedule clients who show up, regardless of whether they're changing or not. It decreases dropout or decreases deterioration rates as much as a third, reduces hospitalizations and shortened lengths of stay by 66%. Here again, added value, saved costs, and significantly reduced the cost of care compared to non-feedback conditions. So I think the case is strong empirically, and we have agencies all over the world that are using the measures in order to achieve these kinds of results in inpatient, in outpatient, in residential treatment settings, in prison settings where clients are mandated into care, and also for use by case managers. In all of these settings, the measures are being used to improve engagement and outcome. And we think working in a feedback-informed way, FIT, feedback-informed treatment, everybody wins. The consumers get individualized care. Instead of delivering standard package treatments to clients, the clinician gets to modify the care to better fit that particular client. Clinicians get their professional autonomy. Since when did the state get to tell clinicians how to practice? That's an individual decision based on the local culture and norms. Payers, however, get accountability. You can take the outcomes and aggregate them and present them to funders so that those funders can see what they're getting for their dollar instead of the number of widgets served. Consumers get their needs met in an effective and efficient manner. Clinicians get to tailor treatment to their client. Payers get the most efficient use of resources, and on and on. We think that the benefits are, in fact, numerous and virtually fits for everyone. Here's one nice piece. Clinicians don't have to learn a new model. They can use the approaches that they were trained in, because the real question is not what is the right treatment approach, but whether the treatment that this client is getting is working for them at this place and time. If not, it behooves us to know that so that we can alter the treatment, change what we're doing, where it's being done, and in some cases, who's doing it in order to maximize the results. This also happens to fit with the APA's definition of evidence-based practice. However, evidence-based practice became synonymous with specific treatments for specific diagnoses. I'll never know. That's not what the definition says. Here's what it says. Evidence-based practice is the integration of the best available research with clinical expertise in the context of patient characteristics, culture, and preferences. I think FIT epitomizes that definition. By the way, clinical expertise, here's how it's defined officially. The monitoring of patient progress, that's what FIT does, and of changes in the patient's circumstances that may suggest a need to adjust the treatment. If the progress is not proceeding adequately, the psychologist alters or addresses problematic aspects of the treatment. In other words, problems in the therapeutic relationship. Well, when feedback informed, clinicians are going to know immediately if there's a problem in the alliance. Why? Because they'll be monitoring that on an ongoing basis with their clients. All this may sound good and simple and straightforward. As you know, any change project in an agency setting is challenging and difficult. So if we switch the topic from what we need to do to how to do it as an agency director or manager, let's talk about some key steps before I take your questions. And what we know for certain is that management commitment is essential. I've been involved in many implementation efforts around the world. In every instance where we failed, management buy-in was weak. How was it weak? Managers treated it as if it were a therapist issue rather than a system issue. How long does it take to make one of these changes? Well, if you're reading any of the recent research from Dean Fixon and SAMHSA and implementation science, you know that it's at least a minimum of 3 years. We have to set some realistic expectations about what will have to happen step by step. Expose all of the clinicians to the basic ideas in a training format and maintain regular contact with a coach, a consultant who can help you while you bring this into practice in your setting. We like to describe the process as 2 phases. First off, creating a bottom-up pilot project. The worst thing you can do is go home and start this tomorrow at your agency. Bring me or someone else in to train them in feedback-informed work. Instead, once you've exposed all your clinicians to the basic ideas, start a pilot project. Set up what we call a TOG, a Transition Oversight Group, that listens to the experience of the therapist working in the pilot project, specifically eliciting complaints, much like we do in a parallel way in treatment when feedback informed, to identify problems at the local level when using the measures. And believe me, there will be plenty. From small, for example, no one copied the measure, to large. It seems that the outcomes are telling us to do things that are against current company policy or agency policy. The second part in phase 1 is to create structures in the organization for peer support and review. In other words, supervisors have to be using the form. There has to be an opportunity to talk about the outcomes, especially when a particular client and therapist are struggling. That means time needs to be set aside for informed discussion and review of the graphs that will result when therapists are using the measures to track outcome and alliance scores. That means having structures in place for new staff. Most agencies are dealing with a turnover rate of between 20 and 25%. The lower the wage, the higher the turnover rate actually is. You'll have to have in place some kind of structure to train the people who will come after the pilot project has started. System 2, after you've done your pilot project, which generally takes about, I would say 6 months to a year, is to implement the findings from your pilot project. Continue with your Transition Oversight Group, a group of pilot project members, supervisors, and generally we always say it's good to have the agency director, somebody who has their hands on the purse strings, can spend money, and can also make policy decisions. During that time in phase 2, you implement broadly. During this phase, 2 things are critical. Number 1, establishing clear policies for dealing with ineffective treatment, ineffective therapists, and ineffective programs. You're going to discover that some of the programs that you have are simply not helpful to the clients. What are you going to do about those? You're going to have some therapists who, no matter how well trained they get, they simply don't help the clients they're working with. It's rare, but it's best to be informed beforehand. The second piece is to develop a continuum of care that extends beyond your agency. What do I mean by that? No matter how good your therapists are, and even once they've adopted feedback-informed strategies, you are going to fail with a certain percentage of your clients. I don't want to alarm you with the figure, so I'm not going to tell you what it is. The question, however, is what are we going to do with those clients? I'll tell you what happens. And this is mostly by failure to address it rather than purposeful. Therapists hang on to cases that they're not helping. Why? Because therapists and social service agencies are good people. They have big hearts. But in a way, their big heart gets in the way of what might be best for the client. We have to set up a plan for where the clients that we don't help will go. That, again, may sound simple. Let me tell you, it is a difficult and complex problem in many ways because when I'm out working with various agencies, they tell me they are the last stop on the behavioral health care train. There is no one else. If that's the attitude, then I promise you we will be keeping clients that we're not helping. The key during this part of phase 2 is to make sure that the structures are in place to carry on feedback-informed work in your particular agency or setting. There are some common challenges that happen when you're trying to implement, creating that culture of feedback where everybody is feeding back to one another. Transparency. Therapists have to be able to see each other work, watch each other work. And then last but not least, what I hope I've made clear is the structure has to be in place for reviewing the outcome data, addressing therapists' programs and individual therapist-client dyads that are not progressing, and moving the clients along the continuum of care. In that process, there are some things that can be of help to you. As part of our review as an evidence-based practice by NREP, this is a small group within SAMHSA that approves various treatments at the federal level here in the United States as evidence-based. We've created a series of manuals, 6 in total. Each one covers a aspect of feedback-informed work. What did the data say? How do you apply this? How do you do supervision? How do you measure and aggregate change? How do you implement, etc.? These are each 35 pages in bullet point format. They're written at a 7th to 8th grade reading level, not because therapists are dumb, but because we're busy. We don't have time to digest complex language. We have to be told, here's how to do it. That's what these particular manuals were designed to do. You can find them on my website. And the second thing that I mentioned earlier, which was to join the online community. Very often, organizations set up a forum just for their clinicians on the ICCE as they implement. There, clinicians can go online and share in private chat with fellow clinicians working at the same agency the difficulties, challenges, and successes they experience while implementing FIT in their clinical practice. Did I say it was free? Doesn't cost anything. No come-ons, no books, ads, videotape. You don't have to buy anything. It really does provide clinicians with a community of people to interact with. In addition, if you can't answer the question, you can go into the community. Thousands and thousands of members are there to answer your questions. Well, those are some basic ideas about introducing feedback-informed work in your clinical setting. And I am willing and ready to take any questions that those in attendance at this webinar might have. Now, I suppose that these questions either have to be typed in, Cindy. I don't know if people can speak live to me if they would like. It's up to you.
Yeah, if you go to the questions on the dashboard, you will see a number of questions that people have entered.
Questions on the dashboard. Now, where is that, Cindy? I've got the chat line, but I am not seeing
something that says questions.
I am not seeing. I see the chat box, but I don't see.
Under the audio, you don't have a box that says questions?
I don't.
Okay.
I have chat.
Well, how about I'll ask you a question then?
That's great.
To reduce paperwork demands, the notion of treatment integrity will need to hold less weight with funders and planners. For this to happen, funders and planners will need to start thinking differently about how therapy works. How do we do this?
I think that's a great question, and I have two responses to it. The first one is stop showing interest in models. There is a reason why there are so many books on models of therapy. Therapists eat them up, and this gives people the idea that somehow that's what we are really interested in. The second is to make the case that what really matters is the outcome. Are you interested in how we do treatment or whether or not the clients get well? Talk to funders about this. Begin showing them your data. Ask your funders, does anyone else have any data about how effective they actually are? We have this data. The third piece is to wait, because the federal government, at least here in the United States, is fully aware of this disconnect between process and outcome. And outcome is quickly becoming one of the main requirements, the measurement of it, the reporting of it amongst the federal government, and I'm sure that will trickle down to other agencies and funders.
Great, thanks, Scott. How about, who do you think presents the most encompassing framework for engagement?
In terms of a model, I think this is again the wrong idea. We're thinking, in contrast to the last question, we're thinking in terms of, if I've understood the question, we're thinking of a particular way of engaging. And so the answer is no one presents that except for your client. The key is not learning a new method for engagement. The key is noticing when our clients are not engaged. Most of the time your therapists are engaging their clients except when they're not. So the key here is to have them notice that. When they notice it, suddenly vistas open up and your therapists are fully capable of connecting with those, with clients. So the way to help to notice is to measure and monitor. And believe me, therapists don't think they need to do it. They need to do it.
Okay, we've got a lot of questions. Here's another good one. Our company has implemented the ORS SRS. Any suggestions on who we can contact for alliance building training?
Well, the number one, I would say that what you actually need to be trained in is not the alliance. What you need to be trained in is how to solicit feedback that can be used to form better alliances with the clients. The one person you can come to for that is me. The second one is to go on ICCE and use the consultation button and solicit one of the 40 or so certified trainers in feedback informed practice. But I want to make this point one more time. We keep thinking in terms of models. You don't need to be trained in the alliance. You need to be trained in methods for eliciting from the client feedback when you fail at the alliance. Just doing that often provides substantial clues about what we need to do different.
Okay, thanks. Here's another one. What are the pros and cons of starting with My Outcomes software versus beginning with the paper version?
Well, when you use a web-based system, you get something that you won't get with paper and pencil, and that is exposure to the normative expected treatment response. In other words, the systems take that client's initial score and compare it to how clients like that client score over time when they're successful. And so you miss that, and we need to be exposed to the norms. That's what you miss when you don't use the system. At the same time, if you want to get started with the paper and pencil measures, I strongly encourage it, and that you use your client as the guide. Simply plot the scores and ask the client, what do they think? Is this enough change? Is our relationship satisfactory to you? Plus, there are some clinical indicators on the scales. Let me give you one of them. On the SRS, any score 36 or lower, any score. And how do you score it? There are 4 10-centimeter lines. The client marks on the line. You measure from the 0 point to the client's mark in centimeters to the nearest millimeter. Add the 4 lines together. There's a total possible number of points of 40. Any score below 36 you should discuss with your client. Anytime a score decreases a single point, you want to discuss that with your client.
Okay, here's another kind of related to that. Is if you have a network of counselors in different locations, how do these counselors use the ORS and SRS forms electronically, handle them on a laptop or a piece of paper, then the counselor enters into a web portal?
Well, I think one thing that most of the web-based services have done is made it very easy to use this on, for example, an iPad or a desktop or a laptop computer. If you're using an iPad, the client simply points at the measure right on your laptop. You hit the button and it shows you the expected treatment response. In addition, you're getting aggregated data, and if you're all spread out, all of your therapists can be organized under a particular supervisor. So that supervisor can look at the outcomes of every single therapist, who can look at the outcome of every single client that they treat. Do you think I got that, Cindy?
Yeah, that was great. That was great, Scott. I see we're just about out of time, so another question.
Okay.
Where do we find the slides for today's webinar?
On my website, scottdmiller.com, and go to the bullet point that reads, let's see if I can find it right here. Hang on with me and I'll show it to you. I think you'll be able to see it here. You go to Scholarly Publications and Handouts, scroll down to the handouts, and the top presentation is Feedback Informed Treatment, Making Services Fit Customers.
Thanks, Scott. And now we do have a number of other questions. I think what I'm going to do is I'm going to field answers to these questions individually to people, and if there's any that I need your help on, I'll just contact you for those.
Perfect. Thanks, guys, for joining us today.
Yeah, and I'd just like to thank you, Scott, for taking this time to share. I'm sure everybody got a lot out of it.
My pleasure. Join the ICCE.
Absolutely. It's amazing. Discussions in there. Okay. Thanks, Scott.
Bye-bye now.
Bye, everyone.